Welcome to another EduMed video, and in this video we'll be talking about the intensive care ward round and specifically looking at the exposure or the E part of the ABCD approach. We'll cover the main examination points of the exposure of the patient and then talk a little bit about the things that are commonly missed. When we talk about the exposure of the patient, it really is exposure from head to toe. You want to check the skin, you want to check the integrity of that, both on the front of the patient and the back of the patient, looking at all pressure areas. Commonly, patients can develop sacral pressure sores, and also really important to bear in mind in patients who are developing a lot of diarrhea, that they can end up with quite significant pressure sores that then become soiled as well. So managing the bowels is really important. The main thing that we want to focus on with the exposure, however, aside from the limbs, looking for perfusion, looking for signs of infection, cellulitis, and making sure that there's no gangrene, which can often occur when patients are on very high doses of vasopressors such as noradrenaline. The abdomen is really important, and we take a little bit of time to look at this. You will often find that patients have sluggish bowel sounds on intensive care, and that's because they're being given large amounts of opiates for sedation, and also other sedative agents such as clonidine and dexmedetomidine can cause some reduction in bowel function. It's really important to always look at the stool chart in intensive care. Patients can very easily and quickly become constipated, and that can be difficult to manage. So regular laxatives are a must for these patients. What you're aiming for is between 2 and 4 formed stool per day. The slight change to that is if they are having fecal management systems. This is essentially a catheter, but you put the catheter up into the rectum and it just collects all of the stool. It's certainly important in patients who are difficult to turn or in patients who are getting lots of loose stool, just to protect the areas around the anus where a stool can otherwise leak and then cause infections and ulcers. In those patients with fecal management systems, you want to aim for loose stool, and so you would be relatively more heavy-handed with your laxative use. In addition to the bowels, you also need to look at the feeding of the patient. Initially, you need to think about how to feed these patients. The vast majority of patients have NG feeding, and it is usually given as continuous NG feeding. Occasionally, patients may need TPN, or total parenteral nutrition. If we are going to give total parenteral nutrition, they need a new central line with one dedicated line that is purely used for TPN and nothing else. That is because it is extremely high risk of developing infection. So if there's any bacterial contamination of that line, it can cause quite significant line sepsis and then secondarily quite significant systemic sepsis. If the patient is being fed with an NG tube, you want to make sure that they're absorbing. And one of the common causes for patients not absorbing is that there is a lack of intestinal motility. So, if patients are started on a feed, and every 4 hours the nurse will aspirate out what is in the stomach. If more than 300 mils of feed are left in the stomach, then it indicates that the patient is not absorbing the feed, i.e. it's not moving through the intestinal tract, and as such prokinetics are used to try and promote movement down into the small and large intestine. This can be done by using medications such as metoclopramide and erythromycin, and it's always worth considering starting these. In general, patients are started on feed relatively soon in their intensive care stay. The reason why feed is important in intensive care is that patients go through different phases. In the first 2 phases, in the first week or so of intensive care, they are highly catabolic. They have an inflammatory state with a high level of cytokine release that causes catabolism of many of the proteins in the patient's body. And that is why we think a lot of patients develop that initial muscle weakness. Now, in order to try and reduce the amount of catabolism of useful structures such as muscles, we try to start them on feeds, and those feeds are there to try and provide some of the energy requirement the patient needs. The honest truth is, a lot of the studies that have looked at total parenteral nutrition versus NG feeding, early NG feeding versus late NG feeding, none of them have really shown a strong signal of benefit of one over the other. However, what we generally do find is that by giving a little bit of feed, we may be able to maintain that gut mucosal integrity and therefore potentially prevent as much gut translocation of bacteria into the bloodstream. Similarly, it can reduce the amount of gastric ulceration that can occur for patients. So, with that in mind, we often start patients with a trophic feed if we're worried about absorption, and that's only 10 mils an hour. Part of that is just to allow a coating of the gastric mucosa and therefore prevent the acid from causing damage and ulceration, but also to maintain gut integrity as well. We then increase up that feed up until a point that they are receiving the majority, if not all, of their caloric intake. There are different regimes for feeding depending upon the type of feed that you're using and how the unit itself gives feeds. Some people give intermittent bolus feeding, and other units use continuous feeding. In general, most patients need between 0.5 and 1 kilocalorie per hour of feed, and that translates to between 25 and 30 kilocalories in 24 hours. Like I say, checking for absorption of the feed is really important, and using drugs such as metoclopramide and erythromycin are useful in trying to keep the feed from going through and therefore allowing absorption in the small and large intestine. It's also worth just reviewing the medications that patients are on, because a lot of them can reduce intestinal motility. Clonidine is significant for causing that, and if patients are getting sluggish bowel sounds or even absent bowel sounds, do think about clonidine, and if they are on it, you could try alternatives such as other sedatives or painkillers if that's what it's being used for. And its younger brother is dexmedetomidine, which certainly shows less gastric side effects compared to clonidine, but it does still cause some. Opiates are commonly used in intensive care, not just for analgesia but also for sedation, the most common of which is fentanyl, and certainly that does cause some intestinal slowing. So if we can wean patients off fentanyl or just reduce the dose, that might be enough to actually improve gut motility. Critically unwell patients often tend to have been unwell for a period of time before coming into hospital, and as such they may have been anorexic for a week or more. With this in mind, when you do start a patient on feed, they can be at very high risk of developing refeeding syndrome. And this is essentially where the body has gone into a quiescent state whilst they've been starved. And then the moment you start introducing glucose into the patient, they start producing lots of ATP. So they suck in a lot of phosphate, they suck in a lot of magnesium and potassium into the cells. And as such, they can become quite profoundly hypokalemic, hypomagnesiemic and hypophosphatemic. And so regular replacement of those electrolytes is necessary. When thinking about the exposure of the patient, there are a number of things that are commonly missed. The most common is actually the pressure areas, because it's quite difficult to turn a patient to actually access the back. Luckily, the patients get washed at least once a day by the nursing staff, and so speaking to the nurse at the bedside, you can often find out whether their pressure areas are intact, and if not, then they will often flag that up for you. The perianal region is a really important region that can get excoriated, especially if the patient has a lot of loose stool. And so if that is the case, do think about things such as fecal management systems, which can shield the skin from getting exposure to more of the caustic diarrhea. Look at every single line entry site, and these are vascular access lines such as central lines, drains, catheters, and always ask yourself the question, do they look infected? Do we need to remove them? If you do think that they look infected or they look erythematous, always have a low threshold for taking it out. Patients are very susceptible to getting intercurrent illnesses and infections, and that can lead on to quite significant septicemic shock if not treated in a timely manner. When you have patients who have diarrhea, always ask yourself, do they actually have overflow diarrhea? Sometimes it's a very difficult diagnosis to make, especially because we can't easily get abdominal x-rays in these patients and their rectum may be relatively empty. So that's where looking at the stool charts over a period of days and weeks is important, because if they've been constipated for 2 weeks and then suddenly start getting lots of loose offensive stool, that might just be the overflow around the fecal plug, and in those cases using enemas and even considering high enemas is important. So the exposure is really important, and probably one of the most important aspects of the examination, because this is often where we pick up on those subtle points that are otherwise lost, like the pressure ulcers or gangrene to the tips of the toes, which may not be examined from any other system. When you are exposing the patient, it is always important to maintain their dignity. Just because they've got sedation doesn't mean that they're not aware, and so keeping the curtains closed, closing the door, explaining to the patient as you're going along, even if you think that they're delirious, is really vital. Always think about pressure areas. No patient should have a pressure source in modern intensive care with regular turning of the patients and with pressure relieving mattresses, but it does happen, and when it does happen we need to manage it early and effectively to prevent it from becoming significant. And certainly those patients who develop grade 4 sacral ulcers with osteomyelitis of the sacrum can be stuck in intensive care and with plastic surgery involvement for months and months, which is a real shame and completely preventable. Also think about bowel management. That goes all the way from the feed that we're giving the patient through to the way in which it's excreted, making sure patients don't become constipated, and at the same time we protect the skin around the anus and the sacrum to make sure that they're not constantly passing too much stool, and adjusting the doses of the laxatives appropriately.